Hello, great delight to be with you virtually. My name is Tristan Barber, and this presentation is entitled Antiretroviral Therapy Updates from CROI 2026. What should change in practice? I just wanted to share this photo of when I was in Mumbai last year and say that I'm very sad not to be there with you in person this year, but I hope to join you on a future occasion. These are my disclosures with regard to this talk. So, in terms of an overview, I'm going to speak first of all about existing long-acting antiretroviral therapy and then present some of the novel antiretroviral therapy data that was presented at the recent CROI conference in Denver. In terms of affecting practice, I think it's very difficult for any of us to see how some of these novel treatments yet will affect our practice, mainly because, of course, access to novel agents remains very variable globally, including in the UK. And of course, in India, you will have access to different antiretroviral therapy treatments. But I still think it's exciting to think about what the future options might be for our patients. In terms of injectable therapy, we've seen a license for injectable cabotegravir and rilpivirine for people who've achieved viral suppression on oral antiretroviral treatment. But we know that there are limitations not only to daily oral treatment, but also to existing intramuscular injectable therapy as well. In terms of daily oral antiretroviral therapy, we know some of the limitations include adherence challenges, issues around stigma and privacy, side effects and tolerability, complexity of regimens, the potential for drug-drug interactions, dosing challenges in those with abnormal renal function, and issues around polypharmacy. And long-acting therapies can overcome these challenges by improving adherence and persistence, reducing stigma, simplifying and making regimens more convenient, bypassing gastrointestinal-related drug-drug interactions, and overcoming problems with renal insufficiency as well. With regard to injectable cabotegravir and rilpivirine themselves, we obviously would like the opportunity to be able to treat people who struggle with oral adherence and have detectable virus. Now, although we're acquiring data in real-world cohorts for the use of injectable therapy in those with viremia, we also have studies that support the use of injectable treatment in areas where monitoring is limited or reduced. The CARES study, which was presented last year, is a study that looked at the use of cabotegravir and rilpivirine in 3 African country settings with limited access to monitoring and showed really good results in terms of virological outcomes here in blue compared to standard oral antiretroviral therapy. We also have the Latitude study that was performed in the US. This was a group of people who struggled with oral adherence, who often had quite chaotic lifestyles with lots of drug use and struggled to engage with healthcare. They were incentivized to be in the study, but nonetheless, on injectable treatment, showed really good outcomes compared to standard oral treatment. We also see a push to have innovative combinations that often are combinations that drug companies will not collaborate to do studies on. And there are data sets looking at the use of lenacapavir with infused intravenous ibalizumab. This is really only available in the USA, but also studies looking at the use of lenacapavir with cabotegravir and with or without the inclusion of rilpivirine. And often the use of these combinations in people with viremia and resistant virus can be very useful to achieve viral suppression. This is a study from Atlanta, again presented in 2025 at CROI in San Francisco, showing the impact of long-acting antiretroviral therapy in a group of people who started with viremia. Now, it's quite small, but of these, 361 people were included, and 81 of those had detectable viral load at baseline. This was 22%. Nearly 70% got cabotegravir and rilpivirine alone, 28% had the addition of lenacapavir, and a small proportion had the addition of ibalizumab. And I just wanted to show that in this group, a large percentage were black, almost all of them, in fact, 93%. A lot had very advanced HIV with an opportunistic infection, and many had socioeconomic issues. But despite all of this, 73 out of the 79 of those who started with viremia achieved an undetectable viral load after a median of just one round of injectable treatment. So we see here that in this group that had difficult to treat virus, the use of injectables in a pragmatic way is very helpful in terms of achieving viral suppression. We now have a study, the CROWN study, which is fully enrolled for adult participants that is looking at the utility of cabotegravir and rilpivirine alone in viremic individuals for whom their oral therapy is failing. And this will definitively answer the question about whether we can safely use injectable cabotegravir and rilpivirine in people with detectable viremia. What's really important, I think, is that if we restrict the use of injectable agents, only a very privileged proportion of people are going to benefit from them. But if we use them in a pragmatic way for people who struggle with oral treatment, I think they can really help us achieve the UNAIDS goals of ending new HIV transmissions and achieving better viral suppression in people with HIV by 2030. And we see here a number of people who may benefit from the use of injectable treatment in this way, including people who are diagnosed but not linked to care, people who are linked to care but not retained in care, people who struggle with oral treatment, and people who are not on optimal oral antiretroviral therapy. So I think the wider use of injectable treatment, when available, will really help more people with HIV to achieve an undetectable HIV viral load. On to some novel treatments. This is all data that was presented in Denver at the CROI conference very recently. This is the 60-41 study. This is a study in people who were already suppressed, who were randomized to either continue on Biktarvy or to switch to oral lenacapavir and islatravir once a week. The outcomes at week 96, this is extended data. The 48-week data had already been presented here by Amy Colson. You can see that at week 96, no patients on therapy had a viral load greater than 50 copies, and no emergent resistance to islatravir or lenacapavir was detected in either group. Adherence was very good, and the safety of the investigational regimen was very good, with no treatment-related grade 3, grade 4, or serious adverse events. Importantly, because of the safety signal that had been seen previously with islatravir resulting in a reduction in total lymphocyte counts, CD4 and absolute lymphocyte count changes did not show any clinically significant changes in this study. You can see the virologic outcomes are really good. So in the blue bar here, you can see the virologic outcomes on the islatravir lenacapavir weekly arm. And in the sort of browny beige color, you can see the outcomes in the group that were on Biktarvy initially and switched to islatravir lenacapavir at week 96. So overall, very good virologic outcomes, and phase 3 studies are underway investigating this combination. We also saw a switch study to daily doravirine islatravir. There were two studies presented, one by Amy Colson and one by Chloe Orkin. This is a switch to daily doravirine and islatravir. You can see the two studies described here. In the 052 study, people were randomized either to switch to the investigational regimen or to continue on oral Biktarvy. And in the 51 study, people were on a range of regimens at baseline. They were randomized to either switch to doravirine islatravir or to continue their baseline combination and switch at week 48. In the 52 study, you see that high rates of virologic suppression were maintained in both treatment arms. Now, there was one incidence of treatment emergent resistance to doravirine and islatravir, but in the Biktarvy arm, there was no emergent resistance seen. Overall, doravirine islatravir was well tolerated, and the safety was comparable to Biktarvy. And there were no between group differences in mean change in CD4 or total lymphocyte counts. And you can see really good rates again of viral suppression in both these arms that are comparable. In the 51 study, again, you see these really high rates of virologic suppression maintained in both treatment arms, no treatment emergent resistance to doravirine or islatravir, and again, switching to doravirine islatravir had no adverse effects on total lymphocytes or CD4 cell count. Doravirine islatravir maintained a favorable safety and tolerability profile. One of the things that's come up in these studies is the importance of making sure that people are vaccinated against hepatitis B before they enter a study with a two-drug combination that doesn't offer any hepatitis B protection. So I think that's a very important safety point to remember. Doravirine islatravir also went head-to-head with Biktarvy in a group of treatment-naive individuals. This is data presented by Jürgen Rockstro. I think it was very brave, actually, of the manufacturers of Doravirine islatravir to go head-to-head with Biktarvy, which we know is an extremely potent and effective treatment for HIV. This was a double-blind, non-inferiority trial in treatment-naive individuals who had to have an HIV viral load of greater than 500 copies, had to not be living with hepatitis B co-infection, and had to have no documented resistance to the drugs that were used in the study. They were stratified according to CD4 count and HIV viral load at baseline, CD4 count either above or below 200, and an HIV viral load either below or above 100,000 copies per mil. In this study, you can see the outcomes here at week 48. So the virologic efficacy was very good. Doravirine islatravir daily was shown to be non-inferior to Biktarvy, also dosed daily. And similar results were seen by the stratified CD4 and HIV viral load groups. 4 people discontinued due to a lack of efficacy in the Doravirine islatravir arm, and 2 of these did show treatment emergent resistance. In the Biktarvy arm, just 2 people discontinued due to a lack of efficacy. Reassuringly, the CD4 and total lymphocyte changes showed no difference between the 2 treatment groups. And both treatments were overall well tolerated. Interestingly, the weight gain was similar in both arms, and this has led to a lot of discussion around our previous hypothesis that the combination of tenofovir alafenamide with a second-generation integrase like bictegravir is responsible for excess weight gain. I think people were hoping that in the doravirine islatravir arm in this naive group of individuals we would see lower weight gain, but that was not the case. Chloe Orkin also presented data from the Artistry-1 study. This is a study looking at people that were on very complex regimens at baseline. The median age in this study was 60 years, and people had a number of comorbidities and also had a lot of polypharmacy. 77% at baseline were on a protease inhibitor-based regimen. So these were a group of people that had been living with HIV for a long time and were receiving complex regimens. And they were randomized in a 2-to-1 fashion to either receive bictegravir lenacapavir, 1 pill once a day, or to continue on their baseline regimen. There were really good virologic outcomes in the Artistry-1 study. The switch to bictegravir lenacapavir was shown to be non-inferior to continuing your stable baseline regimen, and no treatment emergent resistance was detected. CD4 counts remained stable after switch, and bictegravir lenacapavir was well tolerated. There were more drug-related adverse events in the bictegravir lenacapavir arm, but of course you would expect this in a study where a randomized arm included people staying on their existing antiretroviral regimen, and in the other arm people were switching to investigational drugs. But the discontinuation due to adverse events was at a very low rate, so just 2% in the bictegravir lenacapavir arm versus 1% in the stable baseline regimen arm. In the interest of time, I haven't gone into this study in more detail, but I think this does offer a convenient, non-boosted, non-protease inhibitor regimen for people who currently are on very complex antiretroviral therapy. And of course, that can have metabolic benefits as well as avoiding the potential for drug-drug interactions. In the Artistry-2 study, this was a group of people who were stable on Biktarvy, and they were randomized to either switch to bictegravir and lenacapavir or to continue on Biktarvy 1 tablet once a day. The results were very good, showing that the switch to bictegravir lenacapavir was non-inferior to continuing Biktarvy. No treatment emergent resistance was detected, and CD4 counts remained stable after switch. In terms of safety, bictegravir lenacapavir was well tolerated, and there were 2% discontinuations in each of the groups in this study. Moving on to something a bit newer, we see here data from the EMBRACE study. This is a switch to a broadly neutralizing antibody, formerly known as N6LS, now known as lotivibart, with cabotegravir and hyaluronidase to extend the PK of this treatment. People had to be stable on antiretroviral therapy for at least 6 months with an undetectable HIV viral load. They had to have had no prior antiretroviral switch due to a virologic failure, and they had to have a phenotypic test to demonstrate sensitivity to lotivibart. They had to have a CD4 count of greater than 350 cells, and they had to have no active hepatitis B co-infection. You can see the arms here that they were randomized to either to receive lotivibart intravenously or to receive it subcutaneously, both dosed at 4 monthly, or to continue their oral standard of care. Now, these were the outcomes. Lotivibart demonstrated good viral suppression in a high proportion of adults with baseline sensitivity to the agent, and it was generally well tolerated when given as an IV infusion with no adverse events leading to withdrawal. There were no serious or severe immune reactions, but injection site reactions were much more common with the subcutaneous versus the IV administration route. All patients receiving lotivibart via either route of administration reported low pain scores and high tolerability. But overall, it's been deemed that the intravenous route is the one that's worthy of further investigation. Just to conclude, these are some of the other drugs that were presented at the CROI conference. From Gilead Sciences, we see GS3242, which is an integrase inhibitor comparable to others given once a day orally in terms of activity. There's the potential for this to be given as a long-acting intramuscular injection every 4 months, but they're hoping to extend it to 6 months, possibly to pair with lenacapavir as a twice-a-year injectable antiretroviral therapy regimen, and phase 2 studies on this agent will begin later this year. From ViiV, there's VH184, which is a long-acting capsid inhibitor, and again, this is being explored as a long-acting treatment, as an injectable therapy, and the phase 2b study looking at this as initial antiretroviral therapy will begin later this year. Also from ViiV, VH499, this is a so-called third generation integrase inhibitor, again able to be given intramuscularly and subcutaneously, both routes being well tolerated. And again, there's the potential for this to be given twice a year. So I really do think we are looking to the future and seeing the possibility of twice yearly injectable two-drug regimens for HIV infection. Finally, Gilead also presented extended data on their combination of lenacapavir with two antibodies, TAB and ZAB, showing that people could interrupt antiretroviral therapy safely after a one-off injection of these agents. And this combination is also going to be further explored in further clinical trials. So in summary, I think we do now have injectables that can be game changers for both pre-exposure prophylaxis and for treatment of chronic HIV infection. But of course, they can only be game changers if they're available in the right place and for the right people. And I would add, of course, at the right cost. We have daily two-drug combinations that are novel, and islatravir is now looking safe at the revised 0.25 milligram dose without the impact on total lymphocytes or CD4 counts that led to the previous discontinuation of the studies that were looking at the higher dose of 0.75 milligrams once a day. We also have a novel combination bictegravir-lenacapavir that can be used in people who are on complex regimens, and we have extended safety data on a weekly two-drug combination in terms of islatravir-lenacapavir now being explored in phase 3 studies, the Island 1 and 2 studies. In terms of broadly neutralizing antibodies, I think these are starting to look more exciting and less experimental. But again, we have to bear in mind the sensitivity tests that are required, and again, the cost and the ease for people to access these drugs globally. But I think what is reassuring is that the antiretroviral pipeline remains strong, and I think we have a positive future ahead to build on the experience we've had so far of oral antiretroviral therapy and to be able to offer people innovative treatments in the future. Of course, as I've mentioned, these need to be accessible globally, and we have to keep fighting and advocating for access to these drugs for those who need them most. We do not have access to lenacapavir for treatment currently in England, and we have a number of people who have highly resistant virus who would benefit from access to this drug. So we continue to campaign for access to new drugs that can benefit those most in need. I just wanted to highlight the journal that I'm editor-in-chief for. I'd be delighted to receive any of your publications, sorry, any of your manuscripts to be considered for publication in HIV research and clinical practice. And you can always get in touch with me via any of my contact details here. Thank you very much indeed for your attention, and I look forward to taking